Okay, we are going to cover Chapter 24, which is nursing care of the family, nursing care of the newborn and family. Here are the learning objectives. So we're going to start out talking about care management of birth through the first 2 hours of age. First, we're going to start talking about the immediate care after birth. So for the assessment, the immediate care after birth, you want to place the baby skin to skin, dry the infant, place a hat on the infant, and cover the mom and the baby while they're skin to skin. Cover the mom with a warm blanket. Assess the heart rate by palpating the base of the stump. So the base of the umbilical cord, after the umbilical cord is cut, you can palpate close to the baby, the stump, and feel the heart rate. And so you can count for 6 seconds and multiply by 10, and the heart rate should be greater than 100 beats per minute. Next, you place identically numbered bands on the infant and the mother, and so these are the bracelets that you match each time you take the baby in and out of the room, and also get footprints of the baby. So that covers immediate care after birth. I'm going to talk about APGAR scoring. So the APGAR score is a rapid assessment of the newborn's transition to extrauterine life. So if you look on page 551, table 24-1, that has the APGAR score, and I'll tell you for the test and both case studies, you need to literally memorize that, and it'll give you the criteria, and then you assign an APGAR score. So the 5 things that are evaluated are the heart rate, the respiratory rate, the muscle tone, reflex irritability, and skin color. APGARs are assigned at 1 and 5 minutes, but it's important to note that you never delay resuscitation waiting to assign the APGAR. So based on your assessment, if the infant needs resuscitated, you resuscitate the infant, and you don't wait until the 1 minute APGAR to decide if the baby needs resuscitated. You intervene prior to that. So I think you all had some questions on your HESI exam about neonatal resuscitation. So on page 551 in your book is figure 24-1 that covers the algorithm for neonatal resuscitation. Probably the most important things that you need to know on here I wrote down in our class notes. If the baby is term, crying, and has good tone, you just have to do routine care and place the baby skin to skin. If the heart rate is less than 100, the baby's gasping, or has apnea, you start positive pressure ventilation. If the heart rate is less than 60, you do positive pressure ventilation, PPV, and you initiate chest compressions. Next, we're going to talk about the physical assessment, the general appearance, and vital signs. So, as the nurse during delivery, when the baby is born and placed on mom's chest, and you're drying the infant and putting the hat on the infant, you're doing a real quick assessment at the same time. So, you can complete your initial assessment while drying the infant and placing the infant skin to skin. You quickly assess for anomalies, bruises, any type of birth trauma, and make sure the baby's in that general flexion position. These vital signs, it's important that you basically memorize these vital signs. Those will show up again on your case studies that you're preparing for to take on Tuesday. So the vital signs consist of the temp, the heart rate, and respiratory rate. Those are always obtained. The blood pressure is not normally obtained unless there is a reason. So the axillary temp is approximately 98.6 degrees. You obtain the respiratory rate and the heart rate when the infant is resting. You want to obtain those before you get the axillary temperature because that kind of irritates them when they start crying. You count respirations for a full minute, and the normal is 30 to 60 breaths per minute. And you want to count an apical pulse for a full minute. and the normal is 110 to 160 beats per minute. If something comes up that you suspect that you need to take blood pressures, the normal blood pressure range is 60 to 80 over 40 to 50 millimeters of mercury. And you get blood pressure in an upper extremity and a lower extremity. And some hospitals do all four extremities. If the upper extremity systolic pressures are more than 15 millimeters of mercury higher than the lower extremity, you may have a cardiac defect. So it's important to get upper and lower extremities and see what the difference is. The baseline measurements of physical growth, the weight, a normal weight is 5.5 to 8.2 pounds, which is 25 to 4,000 grams. Head circumference, 12.6 to 14.5 inches, which is 32 to 36 centimeters. And the normal body length is 17.7 to 21.7 inches, or 45 to 55 centimeters. For the newborn reflexes, I posted a video that shows how to assess newborn reflexes, and there is some information in your book also related to those. And I have also asked your clinical instructors to review those this coming week during either pre or post conference, because it's really difficult to demonstrate those without having a newborn in front of you. So next we're going to talk about gestational age. Assessment of gestational age is important because perinatal morbidity and mortality are related to gestational age and birth weight. So we know the lower the gestational age or the lower the birth weight, the higher morbidity and mortality these babies have. As far as the gestational age assessment, what scale you use, you may hear in clinical it called the Du Bois or Ballard scale. The Ballard scale has kind of replaced the older scale. So Ballard is what most hospitals are using. With the Ballard scale, you can measure infant age as low as 20 weeks gestation. It's important to perform a Ballard assessment or gestational assessment as soon as possible after birth, and definitely by 48 hours. You're looking for 6 external physical and 6 neuromuscular signs, and then you give a numeric score for each that give you a total score that correlates with the gestational age. So if you look on page 554 in your book, that's exactly what you're looking for. You're doing those different tests on the baby, and again, just kind of correlate this and watch the video, and your clinical instructors will review this in clinicals this week. And here is a picture. At the top, you're looking at the neuromuscular maturity, and at the bottom, the physical maturity, and then you assign a number, and then when you add those up, that correlates with the gestational age. Classifications of newborn by gestational age and birth weight. First, we'll talk about AGA, which is appropriate for gestational age. These infants fall between the 10th and the 90th percentile, and it just means they grew at a normal rate regardless of their gestational age, that their weight was appropriate for their gestational age. The next category are large for gestational age, LGA babies. These are babies that are greater than the 90th percentile. It means they grew at an accelerated rate. And SGA babies are small for gestational age, and they are less than the 10th percentile, which means they grew at a restricted weight. And again, we know that the birth weight and gestational age influences mortality. The lower the weight and the lower the gestational age, the higher the mortality. And here is a chart where you graph the baby's weight and the baby's gestational age. So across the bottom you'll see the gestational age, and up on the left you'll see the birth weight. And then when you plot that based on what color, what area you're in, you'll see if your baby is LGA, AGA, or SGA. So we're going to continue to talk about gestational ages. And we covered some of this back when we covered the labor and delivery, but it's just kind of a reminder that preterm or premature are babies that are born before completion of 37 weeks, regardless of their birth weight. Late preterm are 34 to 36 and 6 weeks. Early term are 37 to 38 and 6/7 weeks. Full term are 39 to 40 and 6/7. Late term is 41 to 41 and 6/7 weeks. Post-term is 42 weeks and beyond, and post-mature is when the baby is born after the completion of week 42 of gestation and showing the effects of progressive placental insufficiency. And we'll talk about how those babies present. So the first category was early term, and these represent 26% of all births due to elective inductions and C-sections prior to 39 weeks. So we know we've started to see a decrease in that. These babies are higher risk for NICU admission, for hypoglycemia, respiratory problems, long-term problems such as learning difficulties. So people just don't tend to think that an early term or a late preterm infant could essentially have so many problems. So late preterm infants, this represents 8% of all births and are the majority of preterm births, are late preterm, and again related to elective inductions and C-sections prior to 39 weeks. These infants are often called the great imposters because they're the same size and weight of term infants. So when you look at them, they look like a term infant, but they don't act like a term infant. So they're at increased risk for respiratory distress, temperature instability, hypoglycemia, apnea, feeding difficulties, and hyperbilirubinemia. And finally, we're going to talk about post-term or post-mature infants. There's a higher rate of mortality for post-term or post-mature infants, and this is related to a decrease in the placental sufficiency. So you actually have placental insufficiency, and the baby's not getting what they need. These babies have very little vernix, no lanugo. They have a head full of hair, long fingernails. Their skin can be cracked, and they can have just a wasted physical appearance. So, you know, they start wasting away because they're not getting the nutrients they need. So they look kind of long and thin and don't have a lot of sub-Q fat.